Hi, I'm Macy and I am going to be making a video about clinical pelvimetry as it applies to midwifery. I'm going to start by telling you about a few parts of the pelvic girdle and most importantly the parts of the pelvis that relate to determining what type of pelvis this woman has. So this here is the ilium, these wings here. And here we have the iliac crest. Down here we have the pubis. And this piece of cartilage here is the symphysis pubis. Down here we have the ischium, and the ischial tuberosities are these. These are basically the bones that you sit on. Now looking down inside, we have the coccyx, the tailbone, and the sacral promontory. These are called the alae of the sacrum. They're basically these little wings inside here. And then these are the ischial spines. And these are typically what we're looking for when we're trying to determine at what station baby is. So to begin with, you're going to want to have a good knowledge of your measurements. So we'll have you measure from here on your thumb, where your thumb bends, up to the tip of your middle finger. It's important to know this to figure out the diagonal conjugate. So mine here is 12. Okay? Another measurement we'll want to know is the width of your fist. So mine is 7. We also want to know what 9.5 looks like. So if you can do this, great, to get to 9.5. But for me, I actually have to really stretch because I have little fingers. So the first thing we're going to do is gain consent to do the pelvimetry. We don't want to just jump on in there during a vaginal exam. I have a cute kitten here who's tearing up my clothes. Okay, so some say that you can start trying to find out the bituberous assessment, which would be the distance of these two sit bones, which are the ischial tuberosities, but actually I think that it would be better to do this at the end of the exam because it can be uncomfortable. So first I'm going to have you take your fingers and insert them into the vagina, and we're going to wait until this part that we first started our measurement connects with the symphysis pubis. And then we're going to reach up and back and try to determine if we can reach the top of the sacral promontory. We want there to be hopefully about 13.5 centimeters. So imagine also that there's tissues, so even though I can do it right on this pelvis, there would be more going on here that I couldn't just necessarily get to it right off the bat. Once you figure out the distance and measure, we would consider this to be narrow or wide, posterior, anterior diameter. Then I'm going to have you turn your fingers, and we're actually going to slide it down the sacral promontory towards the coccyx. You can put a little pressure to see if that moves, and on this pelvic model it does. And we want to determine if the sacral promontory is narrow or hollow. So this one hollow or flat. So this is definitely hollow. There's a nice curve to this one here inside. I'm not sure if you can tell, but then once we're in here, we're going to then slide along the pelvic inlet, and we want to determine that they're both parallel and curved. You want to determine how curved are they. Then we're sliding down to the ischial spines. So this is where I'm going to try to determine the distance of the ischial spine. So if you can do it like this, this is how they actually recommend doing it. And you want this to be 9.5 would be considered adequate, mid-pelvis measurement. So up here we're doing the inlet, down here we're down to the mid-pelvis. You also want to determine here if these are prominent or blunt and parallel. So I would not consider these to be prominent. They feel nice and parallel. So once you're there, you're going to come down and you want to assess the angle of the pubic arch. So what we're hoping for is about 90 to 110 degrees. That might look like 3 finger breadths. However you are comfortable measuring that angle. It's right about an inch inside the introitus. Greater than 110 degrees would be considered wide, and less than 90 would be considered narrow. You know, see if that's extremely angulated. Lastly, we're going to measure the width of the sits bones by taking our fists, and you want to alert the woman before you do this because it can be uncomfortable. And you're going to press against the vulva with your fists and determine how far. We would consider it narrow if they came on the inside of the knuckles. So mine are only 7 centimeters. And we want it to be 9.5 centimeters preferably, or greater. So we're doing this to determine what sort of pelvis the woman has. There are 4 types of pelvises. 50% are considered gynecoid. That's considered the best for childbirth. In that case, you would not be able to reach the diagonal conjugate. You couldn't reach the sacral promontory. These would be parallel and curved right here. 90-degree angle. Outside of the fist. Hollow sacral promontory. And at least 9.5 centimeters. 5% of the population has the platypoid pelvis, and that is the most difficult to give birth in. That would be a very wide transverse diameter, so the ischial spines might be very hard to find. You would definitely be reaching the sacral promontory here. The sits bones and everything would be wide. These would be more short, so it would be more like this, with an oval shaped pelvis like this. 25% of the population has the android pelvis. And that's more of a triangular shape. It's considered the most restrictive, actually, of them all, not the platypoid. And then we have the anthropoid, which is the heart-shaped pelvis, and that's about 20% of the population. So there you have it, clinical pelvimetry. Most women have a combination of pelvises and not just one or the other. Also, clinical pelvimetry is no longer recommended to be used to determine or predict CPD or arrest of labor, and all women should be offered a trial of labor. It can be useful if you have a breech baby to understand the shape of her pelvis. It can also be helpful to know the shape of her pelvis for the fetal head rotation, and to be aware of a possible arrest of descent, such as with a platypoid pelvis. You may expect a mid-pelvis descent because the head cannot rotate until on the perineum, and the anthropoid pelvis, the baby often is born OP easily. Thank you.